All right. Welcome, everyone, to How to Become a Psychiatry or Psychotherapy Jedi, Episode 1, Return of the Therapeutic Alliance. I put in the chat the information on Episode 2, The Dark Side of Psychiatry. I want you to note that psychiatrist in this presentation also refers to psychotherapist. I just say psychiatrist for brevity mostly. And I encourage psychotherapists to be discussing medications with their patients. I hear a lot that there's hesitancy, understandably. And this presentation will cover how to discuss meds while staying within scope of practice. The don'ts of that are going to be the next presentation, but everything we cover in this presentation is fair game. I think is very worthwhile to discuss in psychotherapy with patients. So I'm going to start with my favorite Jedi psychologist, Carl Rogers, who emphasized the importance of relationship. In my early professional years, I was asking the question, how can I treat or cure or change this person? Now I would phrase the question in this way. How can I provide a relationship which this person may use for his own personal growth? Relationship matters. Now, I think traditionally, when we're talking about the significance of our relationship with the patient, we're thinking, yeah, okay, the patient likes me, so they'll take their medicine. I want to emphasize the importance of our relationship with our patients as a treatment effect. 2006 study, 112 depressed patients treated by 9 different psychiatrists, some with placebo, some with imipramine, so this is an old study, right? Was able to stratify patient outcomes by prescriber. So in this study, the most effective 1/3 of prescribers achieved better outcomes with placebo pills than the least effective 1/3 of prescribers got with antidepressants. Thus, relationship is about more than medication adherence. It's about treatment effect. It contributes to that significantly. And placebo effect accounts for about 50 to 75% of therapeutic benefit at times from antidepressants. And also anxiolytics, bipolar disorder and schizophrenia also show a remarkably high placebo response rate. Dr. David Mintz, who writes books on the psychodynamics of prescribing, I highly recommend them. And a lot of his information really inspired my second presentation, especially. He says how the doctor prescribes is even more important than what the doctor prescribes. And if you're thinking this is just a psychiatry thing, well, it's not. On pain treatment, placebos have been found to induce real neurobiological changes on neuroimaging. The same places on an fMRI are lighting up with real anesthesia as they are with placebo that produces pain control. Even a placebo-controlled trial of benzodiazepine medication, which we think of that as having, less of a placebo effect, found that psychological readiness for change was the single most important predictor of therapeutic response, more powerful than whether they got drug or placebo. So there's clearly more at play here than chemicals inside the medication. This also applies to diabetes, in which a study in Italy found that primary care doctors with high levels of empathy had significantly better outcomes. And in an HIV study, there was higher medication compliance, higher medication efficacy, and they got more accurate information from their patients.
Connecting to our patients, yes. Healing for them it is. Healing for psychiatrist Jedi it is too. Sustains us and fulfills us connection does. protects us from burnout. It does.
Thank you to my wonderful husband for my Yoda voices, by the way, Josh. Are the Yoda voices working, Josh? All right, he says they're working. So, as Yoda points out, our relationship with our patients isn't just important to them. It is also important to us, psychiatrists and psychotherapists. And the more we can deepen that relationship, the more fulfilling and sustained we will be in the work. Studies show that specifically after the third year of medical school is when empathy starts to decline in physicians. I think that it's worthwhile talking just for a moment about burnout and compassion fatigue and secondary traumatic stress, even though I have a whole different presentation that covers all of that stuff in depth. Because before we get into how we connect, I want to note that this robs us of our ability to connect. And the culprits, right, are low physician autonomy combined with this sense of complete responsibility, even though we have very little control, extreme burden of administrative tasks, and a just complete continuous state of overwhelm and busyness where more is demanded from us than we can supply on a daily basis. I like this quote by Dr. Pooja Lakshmin, who has an article called "We Don't Need Self-Care, We Need Boundaries." So pay attention to what you can say no to be able to be physically and emotionally in the place where you can connect. So let's start with our golden trio here. The therapeutic alliance. It is the relationship between doctor and patient or psychotherapist and patient that allows the patient to grow and change. I changed the original terms by Carl Rogers. Okay, so originally he's saying unconditional positive regard and congruence and empathy. Let's go over congruence first, okay? I like to call it authenticity. Congruence means that your face looks like what you really feel in the moment. And what you're saying is what you really mean in the moment. Patients pick up on that. And also, we pick up on that when we are being authentic and function better. There's a saying, you will do your best work when it is resonant with your personality. I don't know who said that. I don't remember, but I like it. And then empathy, of course, which we're going to go into some details on that. I changed unconditional positive regard to acceptance without judgment because we are often frustrated with our patients and often don't like them. Yes, I said it. However, even when we're frustrated and don't like them, we fully accept them. We fully care about them. This could also be called love. And Viktor Frankl, Jedi psychiatrist, says, love is the only way to grasp another human being in the innermost core of his personality. No one can become fully aware of the very essence of another human being unless he loves him or her. So, forming a therapeutic alliance. If you have some space snacks to share, that's helpful. We will go over some other strategies though. I want to highlight that in this presentation, I'm talking about things that as psychiatrists and psychotherapists, we are already instinctively and naturally doing. My goal isn't to bring up some completely novel thing that you're not already doing. My goal is to dig down into that mechanism and process of how we connect so that you can do it more intentionally and connect more deeply. So let's start with what is empathy exactly? Just look at this. Ewok is, oh no, his friend, he's not getting up. Oh, right? It gets you in the feels, okay? So first, oops, there you go. Affective empathy, feeling with someone, a shared emotional experience. So there are these mirror neurons, which you may have heard of. The mirror neuron inside your brain sees that sadness in that Ewok. You physically feel sad and helpless seeing the Ewok's pain. That's affective empathy. There's a study done in college students. They looked at photographs depicting emotions, and outside of their awareness, they tested on EMG, the facial muscles. On EMG, the college students' facial muscles would depict the same emotion that they saw in the photograph. So this is a feeling with someone that happens on an instinctive level. Then there's cognitive empathy. Cognitive empathy is understanding another's perspective. One study showed that patients with autism spectrum disorder have lower cognitive empathy, specifically for people who don't have autism, okay, but may have higher cognitive empathy for their fellow autistics, FYI, but are not impaired in any way in affective empathy. Cognitive empathy is, I see this Ewok and I'm like, wow, watching their friend die, I know how that must be. You know, I remember when I lost a friend, they must feel so angry at those stormtroopers and they are going to miss their friend. So you get their perspective, cognitive empathy. Compassionate empathy, concern, caring, that's feeling for someone. Like, I care about this Ewok. I want to help. I'm going to get him into a grief group. I really want to be of service to this fellow creature. I care about what happens to him. I got these information from Dr. David Puder's Psychiatry and Psychotherapy podcast. For those of you who know about it, you know what I'm talking about, and this is probably really familiar. And those of you who don't know about it, go check it out. I really enjoy it. I don't mean to imply with this empathy thing that we are all in to our patient's emotions, okay? It's like an emotional titration with Luke balancing Yoda over there, okay? Between callousness and not enough empathy on one side and emotional over-involvement. So we have to keep our perspective and that rational mind online and not be completely wrapped up in their emotions. It's like a strategic titration from moment to moment, how emotionally involved we are in our patient's pain and suffering or other emotions, also called emotional boundaries. I'm really apologize for this slide. In my imagination, it looked really beautiful, but I'm going to try to help you guys out by walking you through it, okay? The process that we go through when we're connecting. So there's limbic information, emotional info, and it's coming over this imperial shuttle. It's making its way over to and our mirror neurons are like bing, 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 right? And that's what is my patient feeling? What am I feeling in response to what my patient is feeling? And then up here is, I think looks like a dump truck something. I don't know. I got it off the internet and it's going from your cortex over here. I am saying something to my patient and what is my patient saying to me? And then we're shuttling back and forth between our understanding of the perspective taking, that cognitive empathy, the looking for meaning in what our patient is saying, and then that emotional feeling what our patient feels. So it's like 2 limbic systems and 2 prefrontal cortexes shuttling information back and forth. It's a back and forth and an up down between intellectual and emotional processing. And you do it kind of instinctively. How do we cultivate our empathy, right? So we talked about what robs us of empathy. How do we get more of that stuff? Okay. Well, you can tune your mirror neurons through practice. We get tons of practice at this. Just being curious about the feelings of the people you are with. Being curious about your own feelings, especially those that make you uncomfortable. Noticing, when do I feel most connected to my patients and what's going on then? And when do I feel most off and disconnected? And constantly exposing yourself to viewpoints that differ from your own and practicing understanding that different viewpoint and just basically eating, sleeping, right? Not being hungry and tired. And self-compassion. I'm highlighting self-compassion. It's something I've personally struggled with, certainly, right? And am constantly trying to grow in. My favorite Jedi psychologist, Carl Rogers, says, the curious paradox is that when I accept myself just as I am, then I can change. Well, the more compassionate we can be with ourselves, the more compassionate we can be with other human beings. There's this bi-directional growth relationship. I think that one of the biggest perks of being a psychiatrist is the bi-directional self-growth relationship. It's impossible for me to like really be practicing psychiatry right and not be ultimately changing every single day. Practicing psychiatry is not something we do to patients. It's ultimately something we actually do with them. We are student and teacher, healer and wounded. We look into them and see ourselves. And how many times during the day do you tell your patient something you're like, oh my God, like I can't tell myself that? But by doing this over and over again, we change. And our own wounds and insecurities are giving us this implicit emotional knowledge of our patient's suffering. I cannot heal those wounds and not be healing myself too.
I won't watch my educational thing. It's okay.
There's a quote. The greatest thing one human being can do for another is to confirm the deepest thing within him or her. Sometimes the deepest thing within healers is their wounds. So here's a funky metaphor for you. Psychiatrists are like fungi, and psychotherapists, it's like, okay, so the fungus sends out its mycelia and it benefits the ecosystem and the patient grows. And the more the patient grows, the more the fungus grows. Fungi. And not just the psychedelic ones. So there's also a quote that resonated with me a lot by Richard Bach. The quote is, we teach best what we most need to learn. Yeah, that gets me as a psychiatrist. We teach best what we most need to learn. People ask me why I do these presentations. That's why, okay? I'm teaching what I need to learn myself. And that's part of why I practice psychiatry, is because I need to grow myself. So thank you for being a part of this, my teaching and my growing. This is a long list. I'm not going to read them. You can just ponder them one at a time. The personal qualities we cultivate in ourselves to connect with our patients, and kind of think about which ones you really are using in your practice. I remember in residency, there was a moment when I thought to myself, I legitimately can't be a psychiatrist. I'm going to tell you this moment. So I was sitting in a lecture, I think it was about psychotherapy, actually. And at that point in my life, psychotherapy was some kind of weird black box that, like, I didn't know if I had it in me, right? I love psychotherapy now, by the way. So the attending said, before you speak, you should never say anything unless you know exactly why you are saying what you are saying to your patient. And I was like, well, shoot, I'm never opening my mouth again because I do not know why I'm saying what I'm saying to my patient. And I think as I have grown over time, I realize so much of this is very ambiguous. And I do my best work when I simply am just open to whatever is coming up, curious, flexible, creative, and often don't figure it out till later. Oh, that's what was going on between me and that patient. If we waited until we knew exactly what to say and what to do for sure to show up and do psychiatry, nobody would get a psychiatrist. And on that note, know all the theories, master all the techniques. But as you touch a human soul, be just another human soul. It's helpful when we're doing this self-reflection thing, right? To ask ourselves on a regular basis, how do I feel about this patient? Especially when it's something uncomfortable. What do I think my patient is feeling about me, and how does that make me feel? Who does my patient remind me of? What memories, attitudes, or biases might I be bringing into this encounter that are unique to me? Our emotional reactions are powerful diagnostic instruments. So attachment in psychotherapy, there's a quote, to access what our patients cannot put into words, we must tune into our own subjective experience. Patients will elicit within us that which they themselves are unable to verbalize. So the way we feel with the patient is a clue to what the patient cannot say. Psychodynamic Psychotherapy, a Clinical Manual, which is one of my more favorite books. I'm actually making my PAs read it chapter by chapter with me right now. Thank you for your patience with that, guys. Is Deborah Kapanis's in Psychodynamic Psychotherapy, a Clinical Manual. She says, one of the best ways to understand your patient's feelings about you is to be aware of your feelings about them. So we're going to talk about countertransference. Countertransference reactions are clues to what my patient is feeling but not saying, to what other people in our patients' lives might feel about them. And they're clues to us on how our personal history has shaped us. So I think of countertransference as kind of like an unlikely ally. Like, these are some of my Wise Wiki reads. That's on the right, there's a psychodynamic psychotherapy clinical manual I was talking about. I also really love the use of self in therapy and the making of a therapist. Sorry, that slide was a little out of order, guys. Okay, so I think of countertransference as like Kylo Ren. And some of you guys haven't seen the newer movies, which, honestly, guys, I think Kylo Ren is a little turd. So countertransference. We wonder, is he an adversary or an ally? And he's kind of both. Okay, like, he does all this a-hole stuff, but kind of saves the day a little bit in the end, that kind of thing, right? So there he is. He says, I will make you suffer. When your patients feel helpless, you will feel helpless. When your patients feel angry, you will feel angry. I will make you reenact unhealthy relationships in your past and in your patient's past. And you will feel like a fool when you realize that I have seduced you. But a keen awareness of me will connect you more deeply to what your patients are feeling. And only when you face me openly can you truly heal yourself and others. Ultimately, I make you human. Sorry, I can't do the cool voices like my husband, guys. But Kylo Ren doesn't have a cool voice anyway. So countertransference, it's uncomfortable. It kind of sucks,
The
but it's
greatest-
still our ally.
The greatest teacher failure is.
Let's talk about failure. Our failures and flaws connect us to our fellow wounded human beings far more than any wit, rhetoric, or training. And I get the most traction out of the really dumb things I do that I tell my patients about. Like, I remember trying to get my patients to like do the Headspace meditation app and focus more on fulfillment instead of achievement and accomplishment. And I told them how I was so focused on achievement and being competitive that I actually cheated and let my Headspace app run with the volume off so that it would log me as meditating when I wasn't really meditating, just so I wouldn't lose my Headspace streak. So there I am, flawed human being. And I get a lot of traction with stuff like that from patients. Also, we should really get ready to screw things up. Therapeutic rifts and ruptures. I really do see these as a crucible of connection. And this is one of my favorite quotes. When you have never upset a patient, never had a break in empathy, therapy has lacked power. It is a cream puff, not transformative, not deep enough. The connection with our patients is not about always being attuned and getting it right. It's actually much more about how we own our mistakes, we directly address the rifts and ruptures, and we repair the relationship. And there is that, there's actually an amount of discord in the relationship with the patient that's healthy, the crucible of connection. Captain Jean-Luc Picard, yes, I threw in some Star Trek just to screw with people, has a good quote. It is possible to commit no mistakes and still lose. That is not weakness. That is life. One of the most beautiful things about psychiatry is that when we make mistakes, we can still win. Of course, it's also true that we can do everything exactly right. We cannot stop patients from killing themselves. We cannot fix up the entirely screwed up mental health system. So we can do everything right and still lose a lot. But this gift that we get in return is that our humanity and our flaws, through this kind of like therapeutic alchemy almost, can go from poop to gold. So you mess up. Opportunity for psychiatrists to model openness, receptivity to feedback, and self-acceptance of our flaws. Make it so. Opportunity for a patient to experience safety while dissenting or disagreeing within a valued relationship, encouraging more authenticity in their lives. Opportunity for a patient to learn that conflicts can be intimacy enhancing and connect you more deeply. All of this comes from us messing up too. So, what a gift. Let's talk about reconnecting after a rupture. Again, I do not encourage making out with your patients, but some other strategies you can try is self-compassion and focus on the here and now in the relationship, to always be on the lookout for ruptures. So you have to have this openness to your own laws to first be able to recognize when there has been a rupture. Get as comfortable as you possibly can with patient dissatisfaction. Welcome it, treasure it, and practice non-defensiveness. Be like, yes, my patient is expressing dissatisfaction. This is a golden opportunity. Encourage patients to openly disagree with you. Explain that them openly disagreeing with you really helps your work together. And fully own things to deepen the relationship. Like, for example, you're right. When you called me after hours and I answered the phone, the tone in my voice was not good. It was a tone that was like, I don't have time for this. You're right. I own that. I should have waited to call you back. I wasn't in the right place to be there for you. You're right to feel hurt. I learned an important lesson to be more mindful of the emotional state I'm in before answering an after hours call. And I think some self-compassionate talk that I find helpful that Luke is sharing with Grogu here. Perhaps my patient is doing the best they can with limited psychological resources. And our patients often have a lot less psychological resources than we do. It's understandable that I'm really frustrated with my patient because I care about this person and what happens to them. Our frustration comes from love for our patient. Often. Perhaps I'm doing the best I can with limited psychological resources. Perhaps my frustration and helplessness are a clue about how my patient feels right now. It took me a while to get how compassion and frustration are synergistic, that they go well together. I definitely don't want to imply that when we have compassion, we're not frustrated or irritated. It's sort of like, I think of it like vanilla ice cream is the compassion and the chocolate hot sauce is the frustration. And we really want to be fully present with both those emotional states within us towards our patients. And they're delicious together, even though they're seemingly antagonistic. For those of you who want to actually use a rating assessment, this can be helpful for patients to mark on a sheet at the end of each session how they're feeling about the relationship. I don't personally do this, but I think it's an awesome idea and kind of wish I was more on top of it. Reducing shame. Guys, doesn't shame just, it's one of the biggest things that drives disconnection and reduces patients' ability to share things with us and grow. Brene Brown, our LCSW Jedi, says that shame derives its power from being unspeakable. And empathy is communicating that very healing message that you're not alone. Nancy McWilliams is quoted to say, "The appropriateness of any intervention or therapeutic stance should be judged by the criterion of whether it increases the patient's ability to confide, to explore more and more painful self states, and to expand access to more intense and more discriminated emotional experiences." In other words, to elaborate. So that's a lot of words for saying that any therapeutic intervention should be judged based on how well it reduces shame and increases the ability of the patient to share stuff with you. One strategy for reducing shame is to highlight for the patient the adaptive purpose of any shameful symptom. So our psychiatrist, Jedi Ahsoka Tano, is talking to a patient about their sensitivity to rejection and how it is adaptive. Of course, you're sensitive to rejection. This makes complete sense because from an evolutionary perspective, rejection from the human tribe meant certain death. Like you sprain your ankle, nobody's taking care of you, you die. So you feel shame to avoid rejection. Thus, it's really hard to share these things with me. Highlighting the adaptive purpose of a symptom. Here's another weird metaphor that I use. It's like, because, getting patients to share things, that's, I don't know, like 60% of our job. I tell patients that, it's like a dark closet and it's nighttime and there's like weird noises outside. You're like, what is that noise? And oh my God, is there something glowing in my closet? And you imagine it to be this horrible monster. And then you tell your psychiatrist about what's going on and it's like turning the light on. It's a mess. Okay. It is not a clean closet. It is not a pretty thing, but it's just a regular old mess. Shame thrives in the darkness of secrecy and solitude. It cannot survive the light of open acceptance and human connection, which is another big reason that we are focusing on how we connect to our patients, because the more we are connected, the less they feel shame. I tell them I am not a psychiatrist for rational robots. I am just a flawed human being trying to help other flawed human beings. Let patients know I can handle whatever you need to tell me, period. I literally say this on a regular basis, guys, and just pause. I can handle whatever you need to tell me, Pause, pause, pause. Oh, something comes out because they don't like the silence afterwards, right? I will not reject you or dismiss you. It's understandable that this is really hard to talk about. Validate that. Your job as a patient is harder than mine as a psychiatrist. I share with my patients that, I know what it's like to be a psychiatric patient because I'm a patient myself. I sit in this chair as a doctor. I've sat on that sofa as a patient, and I will take my chair over your seat on that sofa any day. It is hard work. I expect you to relapse. That is part of the illness. These are all strategies I use to reduce shame. And I'm sure that you guys can share some of your strategies with me too. Maybe at the end of the presentation, people have some ideas. I'm always open to new ones. I'm quoting Dr. David Puder from the Psychiatry and Psychotherapy podcast here again. It is not that they are continuing to explore things they know they want to share, but things they did not even have access to until you listened in a way that reduced shame and fear, and therefore allowed them to elaborate and talk about themselves in deeper ways. It is hard to feel shame and togetherness at the same time. Togetherness reduces shame. It is hard to feel lonely and connected at the same time. So if we are connecting, the patient feels less lonely and less shame in the here and now of the therapeutic moment. So he's talking about that connection and reduction of shame as a therapeutic tool for the patient to even become aware of new things about themselves. Let's talk about self-disclosure on that note, guys. Some tips on self-disclosure. I think it works the best when we're sharing how we felt similarly, not when we've that we've experienced similar things, like personal history per se, so that you've known shame, you've known sorrow, you've known how it's vulnerable to be a psychiatric patient. You felt inadequate without revealing distracting details of a situation that you've experienced. It's especially helpful to disclose the feelings that you hope the patient will disclose and work on themselves. So it's like an invitation. You get the sense that your patient is feeling ashamed of something. Maybe I'll disclose how I felt great shame. It signals that while we expect our patients to be free with their thoughts and feelings, we're willing to do a little bit of this as well. Especially the thoughts and feelings we have in the here and now. Like, as you're talking about your husband just now, I feel sad and kind of lonely. What's coming up for you as you talk about him? This is also known as playing your cards face up. Like Lando Calrissian, he never plays his cards face up, but we're going to say he does. Using the self means that the therapist has to be willing to face his or her own pain, finiteness, and vulnerability. I got that from the use of self in therapy. Also, self-disclosure can be a trap. Watch out for when we assume that because we've had a similar experience, like losing a child, or we're of a similar religious background, that they are feeling or thinking the same. So ironically, when we've had a similar experience to our patient is when we can fall into these self-disclosure traps because we're readily kind of assuming sameness. Self-disclose with a really healthy dose of humility about yourself and reflect, is this really for my patient or is something coming up with me? This is why it's so important for us to have like really good friends who we can just like word dump on. Thank you, my husband, for when I come home and I can like dump on you. I apologize, but that we can really have those outlets, right? So that we resist the temptation to do that with our patients. It's like at the end of the day, we've taken in so much that we just need to bleh it out. At least that's how I feel. Listening psychodynamically. We think we listen, but very rarely do we listen with real understanding, true empathy. Yet listening of this very special kind is one of the most potent forces for change that I know. So I don't know, sometimes psychiatry can feel like a chess match and you're like, what am I going to say next? How am I going to handle this? How am I going to get them to start taking their medicine again? And we just need to sit back and instead of thinking about our next move, just forget it. Forget your next move. Just hear them. I know I need to work on that some. I really enjoyed the podcast episode that Dr. Puder does on listening psychodynamically. And so I put a couple quotes in here and then I'm going to explain it further. Imagine approaching someone with the mindset that what they say has meaning. Inevitably, they will feel meaningful. They will feel that their thoughts are important and there for a good reason. Emotions aren't nonsense. They have a purpose. When we help them identify the purpose, they can begin to untangle the event that made them emotional and the meanings they assigned to that event. Yalom says, perhaps symptoms are messengers of a meaning and will vanish only when the message is comprehended. So, an example. I'm a child psychiatrist, right? I also see adults, by the way. And this question comes up a lot. Do you have kids of your own? In exactly that tone. So, of course, we want to stay away from the defensive response. If you wanted some parenting tips, you could read a magazine. If you want a thorough psychiatric evaluation, that's what I'm here for. But with this reflective listening skill, right? We're listening for meaning. What are they thinking? What are they feeling? What really matters to them? So there's simple reflection. Just, it matters to you whether I'm also a parent. And there is the more complex question, highlighting, you're worried that if I'm not also a parent, I won't be able to understand what you're going through and I might judge you more harshly. Kind of the meat of it. It's like, especially getting into the gooey, softer emotions, the fear, shame, inadequacy, guilt, and loneliness. I think of it like an egg, and you want to get at the yolk versus the hard emotions, anger, disgust, judgment, resentment. Now, if a patient is openly angry, it is super helpful to acknowledge and bring that into the room. I hear that you're extremely frustrated with me. Tell me more about that. But if you can sense some of the more vulnerable, gooey, yolk of the egg stuff, I go after that and highlight that in the reflective statement. As they say, connect with the underside of the turtle is another way of saying that gooey egg thing. So how do we formulate one of these complex reflections? We ask ourselves, what is the patient really feeling? Both surface and in that gooey center. What's important to them? What are they not saying, but really meaning? And using images and metaphors, like what I thought of or imagined was this kind of thing as you talked. We're thinking about what thoughts, feelings, and meanings lurk beneath the surface, like these cool sea monsters that I really like in Star Wars. So if a patient says they feel lonely, maybe instead of going after it like the content, oh, you're not alone, I'm with you here. Not that that's a bad thing, okay? But you could try, wow, it's really painful to feel so alone. Just meeting that emotional resonance with a similar emotion deepens connection and can ironically make them feel less alone than telling them they're not alone. Listen in a way that tells you what the patient is trying to say about their relationship with you. So, for example, patient says, I feel lonely, but I feel you understand me somewhat. Wait a minute, somewhat? And the doctor could respond, it's important to me to know about times that you might feel lonely in our sessions. It'll be valuable to help us understand that and work through that together. Courage. I honestly don't think we talk enough about how much courage it takes to do psychiatry and psychotherapy. I don't want to give the impression here that connecting with our patients means that our patients are pleased with us or appreciative of us. I mean, sometimes they are. That's very nice. But I spend a lot of time as a psychiatrist being very unpopular with my patients. And as psychiatrists, we are purposely bringing into the room the most uncomfortable, challenging, and painful material for these people. We set limits that pisses people off outright. We ask questions that other people are too uncomfortable to ask. And one of the very popular things I tell my patients is, I'm not here to make you happy. I'm here to make you healthy. And finding health is going to require sacrificing comfort to get freedom. We ask a lot of very uncomfortable things in this work with patients. And we are up against ridiculous amounts of pain and suffering in a screwed up mental health system. I feel sometimes like a gnat trying to hold off a hurricane, which is to say that as a psychiatrist, I often feel quite inadequate to the amount of pain and suffering and the screwed upness of the system. I do want to say, before we all get too very depressed, that I think we lose sight of our strength. It was just last week, actually, I was talking to a patient and all I said a really simple thing. I said, gosh, that took a lot of courage to share with me. I'm so proud of you. That patient, like you could tell when that thing hit, like they were just crying and it was not, like I said, a profound thing, guys. Okay. I didn't have to like read, psychodynamic psychotherapy manual to come up with that. Just, it takes a lot of courage what you shared with me. I'm really proud of you, period. And so, yes, so much of what we do is really hard, but some of it is like crazy easy. Some of it is just it's a treasure how much power and good we can do with a simple statement. So even when we feel like a gnat, often to our patients, we're like dragons. Yeah. On that note, I like Edith Eger's quote, "Don't call me a shrink, call me a stretch, because we make people stretch and get uncomfortable." I do got some bad news though, guys. And that is, okay, the Jedi metaphor is super awesome and fun. So I'm still going to call it psychiatrist Jedi, but the real Jedi and the real hero of the story is the patient. The patient is the hero, not the doctor. So celebrate your wins inside, but always give most of the credit to the patient for the win. Give less credit to your medicine. And ironically, the less credit you give to your medicine, the less likely they are to quit their medicine. Kind of paradoxically. Let the patient be the authority on their life and you be the student. Or as they say in Star Wars, always let the Wookiee win. I'm going to highlight this relationship between doctor and patient here. I really feel like we get frustrated with our patients for not being good patients and fulfilling their role as patients, rightfully so. But sometimes a lot of it is just like, we need to teach patients how to be good patients. That we are two expert co-investigators. Doctor is expert in medication selection and dosage, diagnosis, the frequency of visits, method of communication outside of appointments, right? Patient is expert in their subjective experience, their symptoms, the decision of whether to take medicine, what they value most, the side effects, the benefits of the medicine, their story, their goals. WebMD is not an expert in any of these things. And so we should actively teach patients how to be patients. I actually show this slide sometimes. Like, here's yours, here's mine. Yes. Historically, it was like a doctor is the hero, versus the mental illness, which is the adversary, and the patient is just like the background, just there with the fight, real fight being between the doctor and the illness. Dr. David Mintz says, the patient is not a passive battleground between the doctor and the disease, but an important ally or adversary in the fight. Again, like our dude, Kylo Ren over here, both ally and adversary. And then we have family, and unfortunately, we have insurance companies also trying to get in on it. But now, effective medical treatment is more complex. I also want to talk about connecting with patients who are neurodiverse, because it's different. Often neurotypical rituals of connection, intentional eye contact, small talk, vague open-ended questions can be quite aversive to autistic individuals. Sensory stimuli for them are more than just a nuisance when they are sensitive to them, and can completely derail their ability to process information and provide information. It's sort of like if the lights are bothering them in a certain way, or there's a certain noise, it's like them trying to hear you talking to them is sort of like trying to hear a bell ringing when a bomb is going off in their head. It's just not going to happen. It's important to allow them to stim and fidget and pace and other body movements that they need for emotional regulation. And I get up and move and pace. If they're sitting on the floor, I can sit on the floor. Autistic patients connect to people through their special interests. Okay, so you see them wearing a Pikachu shirt, for example, you kind of have a good idea how to open that conversation. They use their specific interests as their route to connection. So because of their alexithymia too, their inability or difficulty registering what they're feeling, and impaired interoception meaning their ability to pick up on body cues such as hunger and thirst. Open-ended questions about their feelings and bodily sensations can be very threatening for them. So Dr. Rancor asks, "How are you feeling, Luke?" Makes direct eye contact, indicating great interest and concern, right? And Luke is like, oh shit, they're looking at me. And what's the right answer? If I don't answer just right, they're going to reject me like everybody else does who thinks I'm super weird. And then they reject me, and then I don't get treatment, and I'm going to stay miserable. But I really need this person's help. I don't know how I feel, right? Kind of like a deer in the headlights type of response. So I find it super helpful. I have like a list of questions if I kind of know what I want from the person ahead of time, the most important stuff. I think emailing them the questions ahead of time. So it takes off the pressure to come up with a response on the spot during a social interaction. I remove my eye contact. If they remove their eye contact or they're feeling stuck, I do a parallel type of activity. I ask questions that are as direct and concise and specific as possible. Like instead of, how's your sleep? Like, do you have difficulty falling asleep, difficulty staying asleep, or difficulty sleeping too long? It's really good to give them a roadmap for what the encounter is going to look like. So here's what we talked about last time. We're going to talk about this time. Tell me what you want to add to that. And then at the end, you're going to get your blood pressure and pulse taken, right? Allowing alternate forms of communication like writing is helpful. And giving them written instructions due to the executive functioning challenges of people with ADHD and autism. Written instructions are super helpful. It's also important to note the power dynamics here that are at play when working with minorities, women, and people of low socioeconomic status. So individuals from socially disadvantaged groups are more prone to nocebo effect. If you haven't heard that term before, nocebo effect is when people have a side effect to a placebo pill. In my next presentation, part 2, the dark side of psychiatry, we're going to talk about strategies for managing nocebo effect. But please, keep in mind the background, the neurotype of your patient, and the power dynamics there as we're trying to connect with people.
Curiosity you must have, ever mindful of your power over your patient, and humble of your knowledge you must be.
Thank you, Yoda. Wise words. Now, we're moving on to encouraging patients to take medication. This is the last third of this presentation, and then I'll be wrapping up to take questions. Thank you. Oh, good old Carrie Fisher. We miss you. She says, living with manic depression takes a tremendous amount of balls. Let's talk about addressing stigma of psychiatric medication. I feel like as a psychiatrist, with all the stigma and the shame and the everything, that like doing an initial intake appointment with a patient kind of feels like going to a job interview where the person who's interviewing you has heard all the terrible rumors about you. So this is tough, encouraging patients to take medication. Psychotherapists can really ally with us, psychiatrists. Help us out, guys, in discussing medication, reframing taking medication as a strength instead of a weakness. That taking medication means using every resource at your disposal to achieve health. That taking medicine requires courage. Help us with dispelling common myths about medicine, that most meds are not addictive, and a lot of people are able to come off of medication. You're not stuck on the medicine forever, though you might find that you want to take it the rest of your life. That medicine isn't meant to change who you are, alter your personality. I tell my patients, you're dating the medicine, not marrying it till death do you part. You decide if you want to take it on more dates or not, and stick with it. And that medication neither represents weakness, an easy way out, nor will it actually accomplish the work of achieving health for you. So managing expectations is important.
Named your fear must be, before banish it you can.
I encourage both psychotherapists and psychiatrists to explore with their patients. What does taking medicine say about you? What does it mean, right? Often there's fears of weakness, deficiency. What are your greatest fears about taking medicine? Often it's about loss of control, fear of dependency, loss of identity. What does your family think about psychiatric medication? What are their spiritual and religious beliefs and how they play into their understanding of mental illness? The family of origin's attitudes towards medication. All of these things are important for us to understand as psychiatrists and are very fruitful for psychotherapists to be discussing. And okay, always end with hope. I ask my patients, imagine yourself in 6 months after being on the best possible medicine I could prescribe you. Tell me what's different. What would be your best hope for what happens with medicine? I get some good stuff in answer to that question that kind of helps me direct their treatment too, so that's nice. Often we get kind of focused on the side effects of medicine. Even as a doctor, right? I'll be like, wait a minute, did I just almost forget to tell them what they're supposed to feel on the medicine, right? What the medicine is supposed to do. And change begins with hope. it's not enough for the patient to want to change. They have to believe the medication can help them change and feel confident that they can. So they have to, from our traditional motivational interviewing, they both want to change and they believe they can. It's like a balancing act, guys, because we want to instill lots of positive expectations of the medicine, as that will make the medicine work better, right? But also, we want to emphasize the patient's self-agency, autonomy, and belief in their own power to heal themselves. It's a balancing act. So, of course, I created a funky metaphor to deal with the issue, explaining how medication is both essential for the change, but the patient is responsible. So imagine yourself at the bottom of a lake and everybody's like, you got to get to the surface. You really need some oxygen. And you're trying, but there's a weight on your ankle. It's an invisible weight that other people can't see and you can't see. It's called insert whatever psychiatric illness you're treating. Anxiety, depression. The medicine takes the weight off. The therapy and you seeking meaningful, healthy relationships, purpose, physical fitness is the swim. So we're explaining medicine in a way that it's freeing the patient to be their authentic self, not controlling the patient, right? It's freeing the patient. We're emphasizing the patient's self-agency and giving the patient responsibility for achieving health. There's this saying, this illness is not your fault, but it's still your responsibility. That applies here.
The power within you to make yourself better, we will reveal together.
Yes, Yoda. So focus medication discussions on empowerment and the patient's role in successful treatment. Cultivate that internal locus of control. Say, let's talk about what you can do to make the medicine work better. Seeking meaningful and fulfilling activities, connecting to healthy people, nutrition, sleep, physical activity, and pay attention to how you are feeling and functioning so you can assertively communicate that to your psychiatrist, please. Focus the discussion on promoting freedom. Patients are very afraid of being controlled, and rightfully so. There's real horrors in our history of psychiatry. So we want to keep promoting their freedom, their self-agency, and their authentic identity. For example, Jedi psychiatrist Qui-Gon Jinn says, on stimulant medication, Obi-Wan, you have more freedom to choose what you focus on and what you tune out. Versus the medicine will make you focus, right? Luke Skywalker, promoting self-agency and identity. Unencumbered by your depression, our goal is for you to be your most authentic self on sertraline, not weighed down by the depression. Again, focusing on authenticity.
Choice of illness, you have not. Choice to either face illness and take medication, or deny and hide, you have.
Emphasize to patients that unfortunately we don't choose our diagnosis. That would be nice. It's not a choose your own adventure kind of thing. The choice is not that. But while we do not choose the illness, we do choose whether we seek treatment for it. That's where their agency lies. Luke Skywalker, psychiatrist Jedi. I'm not here to tell you what to do. I'm here to provide information to help you make a decision about medication that is driven by your values and medical evidence rather than fear. On that note, right? There's a study in 2010, 403 patients with depression. They found that when patients were more involved in treatment decisions, and these are like really stupid, simple decisions, like, are you going to take the medicine once a day, or are we going to divide it up and do it 3 times a day? Which one would you like, right? Just given a very simple choice that was not like clinically or pharmacologically relevant. They were 2.3 times more likely to continue taking their medicine. Patients who disagree with their diagnosis or felt uninvolved were 7.3 times more likely to stop their medication. Now, again, unfortunately, patients don't get to choose their diagnosis, but you see the power of whether they feel that they have a voice, whether they feel that they have a choice, has on their treatment outcome. And there's a 2006 study showed that patients being treated for depression by primary care doctors found that the degree of patient involvement in medical decision-making directly correlated with the degree of improvement 18 months out. So, if there's an opportunity to give a benign, non-pharmacologically relevant choice, why not? Addressing the naturalistic fallacy. Doesn't this come up a lot for you guys? I imagine. Oh, I'm holistic. I avoid medicine, right? And so then I draw a pie chart. I actually have a whiteboard in my office and I draw a pie chart, okay? And I talk about the naturalistic fallacy, which is that the belief that what is natural is safe and what is man-made is harmful. And I'm like, okay, a holistic approach means all of the resources, your nutrition, your exercise, your relationships, your meaning and purpose, and medication. A reductionistic approach is cutting things out, i.e., I am cutting out medication. And, of course, lithium is a great example for the naturalistic fallacy. What's really inside a pill, guys? So medications are both biologically and symbolically active. They have meaning to people. And as a psychiatry Jedi, we're doing more than chemicals. We're addressing that meaning. There's the expectation of harm or benefit. There's reenactment of relationships with early caregivers or past prescribers with the current prescriber. Does the medication symbolize an illness or deficit? Does the medication symbolize soothing? Or does the, power and control dynamics? I actually did, alter a picture of the Concerta pill to make this slide. It's rough. We never know what we're walking into. So I'll leave you with this personal self-talk that I give myself pretty much every day when I'm trying to reassure myself to not freak out. If I can connect, I'll be okay. I hope it helps you too. Next time, I'm really excited about the next presentation, guys. Psychiatry Jedi, the dark side of psychiatry. The psychological meanings patients hold of medications and early attachment relationships and how they impact treatment. Addressing resistance, overuse of medication, the dangers of biological reductionism and psychodynamic reductionism. I have some trailer slides. It makes sense that you're afraid of being dependent on the medication. Let's talk about your fears and your goal to eventually be off of medication. Leia correctly intuiting how Han's avoidant attachment style is impacting his treatment alliance with his psychiatrist and encouraging overt instead of covert disagreement, i.e., I'm stopping my medicine without talking to you instead of to your face, hey, this is my frustration. Overuse of medications. when medications replace healthy attachments to people?
You just have a chemical imbalance.
The dangers of biological reductionism. Defensive use of diagnosis. And more. All right, congrats guys. You made it through my whole presentation. I left the last 12 minutes to answer questions. So I'm gonna stop my screen share and say hi to everyone. Thank you so much for listening. I really appreciate it. I'm gonna look in this chat and see what people have to say. And people, please feel free to like unmute yourself and ask questions, okay? Let's see if there are any questions. Andrew says validation tears. Thank you, Andrew.
Stacey, I
Hi.
have a question.
Yes,
I have a question for you.
please.
So, I was curious if you could comment on your opinion about like this idea that, there's like this placebo effect or nocebo effect.
Mhm.
And, I think there's a cohort of people out there where they feel like if the medicine, like even if it's not evidence-based treatment, but a
Mhm.
patient gets better, right?
Yeah.
They improve,
Right.
then does it matter? And again, too, I know that's a kind of that goes
Right.
against my medical training and kind of evidence-based treatment, but I do think that there are people and patients out there where they don't care, right? Like they don't care about the study, they don't care about the results, they care about getting better. And if there's some
Yeah.
intervention and it's not evidence-based, but they get better, like, is that okay? Like, I know that's, I don't know how much you
I
deal with
support
that on
it.
a
I mean, I think
day-to-day
as long as
basis.
it's
Yeah.
not harmful. I'm gonna say, because placebo effect is real effect, right? Like, so you're looking at fMRI. Oh yeah, now you can, oh, you can't see my ears. Hold on one second. I have Yoda ears, by the way, but my background hid them. Anyways, placebo effect is a real effect, and I will take it as long as there isn't harm. I think that we can be open with people, but I'm okay with that. What do you think, Dr. Liu? What is your opinion?
What a excellent and true psychiatrist for answering a question with a question. No, I mean, I think it's something worth thinking about, because I do worry, as kind of, I work at the University of Oklahoma, an academic center, and so obviously we really focus on evidence base and things like that. But I really worry that we may be alienating, whole large groups of populations who are interested in different types of care that might not be evidence-based. And I find that the majority of the time I'm trying to answer questions about things that we don't know about, right? Versus the things that, no one's ever coming in and saying, tell me about the randomized controlled trial about, treatment of ADHD with methylphenidate, right? They're coming in and asking me about, well, hey, I read this article and or saw a TikTok on CBD or something like that. Like, tell me about that. That's what I'm actually really interested in. And so, so I think, I don't know, I'm trying to have a measured approach to it, if that makes sense.
I mean, I think it's important to then ask people like, what's underneath that search for something else, right? Is it fear that their kid is going to be a zombie? Or is it the naturalistic fallacy that we talked about? Like what's under that question, what I like to ask people often what the worst possible scenario they could see happening from me medicating their child is.
Thank you, Dr. Gruder.
Yeah, because it's like, why are they bringing up CBD? Why do they want something like that, right? Something's going on, something's at play. Yeah, and we're rational beings. We don't treat rational robots. Yeah, Thanks, Dr. Lu. Other questions, guys?
I have a question.
Sure.
Kind of working with, well, I work with ages 4 and up. I don't really know how to go about questions when it's, well, is my child too young to be on medication? Because I don't know the answer to that. And maybe I do need to be knowing the answer to that, but I don't
I
know.
mean, maybe there isn't an answer to it too, you know?
Yeah, I don't
Like these things are
feel
pretty
qualified.
ambiguous.
Yeah.
Yeah.
Okay.
I mean, I think you're right. Like you don't know that. Well, first of all, there isn't really an answer to that question. That's a clear-cut answer, A, that exists. So that's one reason you don't have an answer. And B, you know, be like, hey, it's really great to talk with an expert doctor on any concern or fears you have about the medicine. Remember that when you go to see a doctor about medicine for your child, you can leave that appointment and never give your child the medicine, or you can take it and stop it. You're going to get information to make a choice. The doctor doesn't make the choice about the medicine. They're just someone who you're getting information from.
Okay. Yeah, I find I'm more comfortable saying that to, you know, kind of preteens, teens. It's the younger kiddos where I find that I'm like, maybe you get a psychological eval, and then I'm kind of like, I guess maybe that referral should come from them. I don't know. I mean, would that be a step first?
Yeah, I think you can. I mean,
Okay.
and it depends on what you're treating, right? Because, okay, so, you know, is it like OCD and they haven't tried exposure response prevention yet? Or is it ADHD where we find that the earlier we start stimulant medication, the more neurotypical brain development we get, right? So there's a lot to it.
Mhm.
And I think that parents need our help in how to be active investigators, you know, when it comes to psychiatric treatment, and like ask your doctor, why did you choose this diagnosis for my child? Did you consider other ones? Why this medicine in particular? Did you consider other ones? Are there books I can read? Are there articles I can read about the medicine that shows that there's evidence behind it, you know, and really, really encouraging them to be an investigator, to that they're a parent. They're not supposed to have the answer. They need to go investigate.
Okay. One last question. I know you
Sure. I hope that helps answer. Yeah.
Yeah, no, that does. That
Okay.
helps. You know, I find that sometimes I'll have like, well, you know, if we go to an appointment, they're going to, you know, think we're there for medication and they're gonna prescribe something. Is that the case? Like,
I don't always prescribe. I know
Okay.
Dr. Lu doesn't.
Okay. Okay.
Some do, right? I mean, I'm not right, but
Right, you can't speak for everybody. Okay.
it's not, no. I don't always prescribe a medicine.
Okay. Thank you.
Cool. Good questions. Other questions, guys? I'm going to pause the recording.